previous talks, but I still think it's valuable information and good data. All right, no conflicts of interest. So the natural history of type B dissections is not great, with about 1 in 4 patients dying out to 3 years, as you can see by these survival curves. Okay, and this study was out of Mass General, where they looked at patients with acute uncomplicated type B aortic dissections. They took all aortic syndrome patients over the course of 12 years and deduced that down to 298 patients with type B aortic dissections. Of this cohort of patients that were being medically managed, 12.4% had early failure, 5% died, and had 8.4% requiring urgent intervention while still in the hospital. At a mean follow-up of 4.3 years, 58.4% failed medical management. There was death in 38% of patients, and about 29% of patients had aorta-related interventions, most requiring open aneurysm repair. About 55% of patients had intervention-free survival out to 3 years, and 41% of patients had intervention-free survival out to 6 years. Reviewing the INSTEAD and INSTEAD XL trials, which Dr. Vayuka had highlighted earlier, just a few important points here is that the all-cause mortality was similar between the medically managed group and the TVAR group. Again, these were uncomplicated type B aortic dissection patients. The biggest contribution of this study was really the fact that about 90% of patients had favorable remodeling at the 2-year mark. What this basically means is regression of the false lumen, expansion of the true lumen, and so those are features of favorable remodeling. When looking at the 5-year data, and again, Dr. Vayuka already highlighted this, so I'll brief through it. There was a reduction, an absolute risk reduction of around 12.4% in aorta-specific mortality and a 19.1% absolute risk reduction in disease progression. If you look at the data in a granular fashion, majority of mortalities were observed in the first 2 years in those patients undergoing TVAR, while the majority of mortalities in the medically managed group occurred after 2 years. So you can see that those that are medically managed, if they live long enough, are likely to have an aorta-related complication and possibly death. So again, the big question is here, is there a high-risk subset we should consider treating? Now, what are the predictors of aortic growth, and can these predictors of aortic growth really direct our management of these patients? Again, the aortic diameter at initial presentation, the morphologic characteristics of the true and the false lumen, the status of the false lumen, location, size, number of entry tears, morphology of the dissection, age, ethnicity, and history of connective tissue disorders. When looking at the aortic diameter at the initial presentation, if you look at all comers, the freedom from aortic-related event at 5 years was around 75% in this study, and at 10 years, 67%. However, when looking at patients with an aortic diameter at initial presentation greater than 4 centimeters, these patients had a hazards ratio of around 3.5. And for those that had intramural hematoma with a localized penetrating aortic ulcer, these patients had a hazard ratio much higher, 14.5%. And this is what we're basically referring to. When you have a patient that comes in with a bad type B dissection, measure the aorta initial diameter being large. This patient, of course, already has an aneurysm and an acute dissection. Of course, this type of patient is very concerning and may need earlier intervention. The false lumen diameter, again, a false lumen diameter greater than 22 millimeters is predictive of late death. If you look at overall event-free survival, is much worse when the false lumen is larger and approaches around 50% at the 6-year mark. And then size and location of the entry tear. This is also very important. To summarize this, a entry tear bigger than 1 centimeter is much worse than smaller entry tears, and proximal entry tears are worse than distal entry tears. Again, this is showing a very large, approximately 3 centimeter entry tear in a patient with an acute type B dissection. This, coupled with other features, is a bad prognostic sign and indicates the likelihood that this aorta is likely to expand into an aneurysm over time and result in an aorta-related death or reintervention. There's also the issue of a partially thrombosed false lumen. This has been determined to be a risk factor for late aortic complications, partial thrombosis being worse than complete thrombosis or patency in terms of overall mortality. Part of this is somewhat hard to explain, but could be due to the lack of outflow within that false lumen, as some of the fenestrations distally are being thrombosed, and the more proximal false lumen is being pressurized. That's what I postulate as being a possible mechanism behind this. The morphology of the true lumen, again, having a very large false lumen and a compressed or elliptical true lumen is a high-risk feature unto itself. The fusiform index, basically taking the proximal aortic diameter where the vessel is more normal size, the distal aortic diameter where the aorta is more normal size, and then the aneurysm diameter. For example, the patient that we were going to treat, which was supposed to be the live case, today had a fusiform index of around 0.85, which is high risk for subsequent aneurysm formation, false lumen expansion, and death. And again, this is looking at survival curves. The higher the fusiform index, meaning the larger the aneurysm in relation to the native aorta, the worse the survival. These, what we call ulcer-like projections or penetrations within the aorta are also high risk and are risk factors for false lumen expansion and aneurysm formation. And again, you can see that these are much higher risk based on these survival curves. Both survival is worse if you have an ulcer-like projection, and the freedom from an aorta-related event is also worse in these patients. So the factors leading to aortic dilatation, just to kind of summarize, an aneurysm at initial presentation, so an aorta greater than 4 centimeters, a large entry tear greater than 1 centimeter, a large false lumen to begin with, a partial false lumen thrombosis, fusiform index greater than 0.64, a patent false lumen, these ulcer-like projections, a single large entry tear, elliptical true lumen, male gender, younger age, and those with connective tissue disorders or Marfan syndrome. The influence of multiple risk factors, these are cumulative. So if you have a large aorta along with a large false lumen, patent false lumen, large fusiform index, when you add these together, these patients tend to have worse survival overall, and these should factor in our decision-making when determining whether to treat these higher risk cohorts. This is from Stanford. Dr. Michael Dake put this algorithm together, or basically a decision-making tree, when thinking about these uncomplicated dissections and determining whether we should treat or not treat these high-risk uncomplicated type B dissections. One of the caveats here is that these high-risk uncomplicated type B dissections, if we're going to perform TVAR in these patients, that we perform TVAR in patients that have good life expectancy so they can actually see the benefit of the treatment in the future. And they provide a bunch of references here as well with that. Thank you very much.